بسم الله الرحمن الرحيم. Wounds and wound healing. عماد الصغير. Definition: a wound is a break in the integrity of the skin or tissues, often which may be associated with disruption of the structure and function. هنا احنا ما قلناش skin بس، قلنا skin or tissues، لان احنا هنشوف دلوقتي ان some wounds skin بيكون integrity skin integrity بيكون normal زي ال closed wounds. There is many classifications of wounds. First, there is teddy wounds and unteddy wounds. Teddy wounds, they are wounds like surgical incisions and wounds caused by sharp objects. It's incised, clean, healthy wound without any tissue loss. Usually primary suturing is done. Healing is by primary intention. Unteddy wounds, they are due to crushing, tearing, avulsion, devitalized injury, vascular injury, multiple irregular wounds, or burns. Here there is tissue loss. There is tissue loss. Also, wound adhesions, infection, delayed healing are unteddy wounds. These wounds need liberal excision of devitalized tissue and allowing for total to heal by secondary intention. Secondary suturing, skin grafting, or flap may be needed here. Also, there is classification according to the skin integrity, either closed wounds or open wounds. Closed wounds like contusion, abrasion, and hematoma. Contusion means minor soft tissue injury with discoloration and hematoma formation without skin break. Hematoma, it may be subcutaneous, intramuscular, subfacial, intraarticular. Small hematoma will get absorbed. Large hematoma, once get infected, forms an abscess, and so it should be drained under general or regional anesthesia. Also, we have abrasions. Abrasion means it is superficial and it's due to shearing of skin where the surface is rubbed off. It heals by epithelialization. It's only epidermal injury, exposing dermis and dermal nerves. Open wounds like incised wounds, lacerated wounds, crush injuries, and penetrating injuries. Incised wound, it's clean cut wound with linear edge. Lacerated wounds have irregular edges with devitalization of some part of tissue, which need wound excision and primary suturing. Crush injury caused by war wounds or road traffic accidents. It leads to complications as muscle ischemia, compartment syndrome, gangrene, loss of tissue. In penetrating wounds, it's due to stab injuries. Common example is stab injury of the abdomen. Stab wounds may be small on body surface, but damage to deeper organs like liver, spleen, major vessels like inferior vena cava, mesenteric vessels, or intestine may be extensive and life-threatening. These patients need more investigations as CT or abdomen and may need laparotomy. There is another classification called simple wounds and complex wounds. Simple wounds where only one tissue is involved. One tissue is involved, either skin or other deep injury. While complex wounds, there is more than one tissue involved, as vessels, nerves, tendons, or bones are involved. There is another classification according to the time elapsed from the occurrence of wounds. It's called acute wounds or chronic wounds. Acute wound up to 8 hours of trauma, where the patient come within 8 hours from trauma. Chronic wounds where the patient comes after 8 hours of trauma. This is important because the first 6 hours the wound was clean without bacterial contamination. After 6 hours or 8 hours, it will be in, infected or it will be contaminated by bacteria. There is also another important classification of wounds, which is classification of surgical wounds. Our surgical wounds, wounds of operations, either clean wounds, clean contaminated, or dirty wounds. Clean wounds like herniorrhaphy, like thyroidectomy, like surgeries of the brain, surgeries of the heart, transplant surgeries, surgeries on joints, etc., where there is no colonization of bacteria or there is no contamination with bacteria. Infection rate in these operations is less than 2%. Clean contaminated wounds where we open a viscous or we operate on a hollow viscous, like appendectomy, bowel surgeries, and elective bowel surgeries where the bowel is prepared, gallbladder, biliary and pancreatic surgeries. Here the infection rate from 2% up to 10%. Contaminated wounds where there is colonization with bacteria, like acute abdominal conditions, open fresh accidental wounds. Here the infection rate is up to 30%, from 15 to 30%. While dirty wounds, these wounds are infected wounds, as abscess drainage, biocele, empyema of gallbladder, fecal peritonitis. Here the infection rate is between 40 to 70%. As regards wound healing, types of wound healing. Wounds either heal by primary intention, secondary intention, or tertiary wound healing. Primary healing or first intention, it occurs in a clean incised wound or surgical wound. Wound edges are approximated with sutures. There is more epithelial regeneration than fibrosis. Wound heals rapidly with complete closure. Scar will be linear, smooth. Healing by secondary intention or secondary healing, it occurs in a wound with extensive soft tissue loss, like in major trauma, burns, and wounds with sepsis. It heals slowly with fibrosis. It leads into a wide scar, often hypertrophied and contracted. and may lead to disability. Re-epithelialization occurs from remaining dermal elements or wound margins. Healing by third intention or tertiary wound healing or delayed primary closure. After wound debridement and control of local infection in infected wounds, wound is closed, wound is closed with sutures or covered using skin graft. Primary contaminated or excised tissue wounds healed by tertiary intervention. Primary contaminated or mixed tissue wounds healed by tertiary intervention. يعني tertiary healing بيحصل في contaminated wounds from the start or in mixed tissue wounds, complex wounds from the start. Stages of wound healing. هنا عندنا stages of wound healing وعندنا phases of wound healing. الفرق بينهم ايه؟ في ال stages of wound healing انا بشوف بعناية by my naked eyes these stages. It's clinical stages. Stage of inflammation, stage of granulation tissue formation and organization. Here due to fibroblastic activity and synthesis of collagen and ground substance. I see by my naked eye either inflammation, then I see granulation tissue, then stage of epithelialization which covers the granulation tissue, stage of scar formation and absorption, and finally stage of maturation. This is different from phases of wound healing. In phases of wound healing, it's mainly pathophysiological phases. We have three phases: inflammatory phase or exudative phase, proliferative phase or fibroblastic phase, remodeling phase or maturation phase. In inflammatory phase, also we called it lag or substrate or exudative phase. It begins immediately after wounding, lasts from 4 to 6 days after injury. Here there will be features of inflammation as redness, hotness, swelling, loss of function. In this phase, the inflammatory cells and inflammatory mediators plays roles in this phase. Macrophages secrete fibroblastic growth factor, which enhances angiogenesis. Angiogenesis means new vascularization or development of new capillary networks. The polymorphonuclear leukocytes appear after 48 hours, which secrete inflammatory mediators and bactericidal oxygen-derived free radicals. These cells also remove the clots, foreign bodies, and bacteria. Chemical factors involved in wound healing in this phase as growth factor, interleukin, tumor necrosis factor, prostaglandin, coagulase, elastase. In this phase, chemotaxis causes neutrophil migration first and then activation of macrophages, lymphocytes, leading into phagocytosis, wound debridement, matrix activation, angiogenesis. Chemotaxis factors are complement factors. Interleukin 1, tumor necrosis factor alpha, tumor growth factor beta, and platelet factor. Activated macrophages produce free radicals and nitric oxide, release cytokine to activate lymphocytes, which release interferon and interleukin. called as lymphokines. These actions are reduced in diabetic patients and in some diseases like Cushing syndrome and in immunosuppression increases the rates of sepsis. Here's the second phase or proliferative phase or fibroblastic phase. Here's the major playing role is the collagen and the glycosamines, which are produced by fibroblasts. It begins after the inflammatory phase from day 7 and lasts for 6 weeks. 80 to 90% of the final strength of wound in post-operative wounds is achieved in 30 days. The difference between the proliferative phase and the inflammatory phase that here the wound becomes stabilized to some extent. Hydroxyproline and hydroxylysines are sensitized by specific enzymes using iron, alpha-fetoglutarate, and vitamin C. Tropocollagen is produced, which aggregates to form collagen fibrils. Here, proliferation of venular endothelial cells with fibroblasts at wound margin and bed occurs by the action of cytokines and released growth factors. This angiogenesis and fibroplasia causes formation of granulation tissue, which contains fibroblasts, new capillaries, collagen, and hyaluronic acid. And later on, neutrophils and macrophages dies, which are cleared by lymphocytes into the draining lymph nodes. The third phase or last phase, which is phase of remodeling phase or maturation phase. It begins after 6 weeks and lasts up to 2 years. Why it begins after 6 weeks? Because after 6 weeks, collagen production is not present. Collagen production stopped after 6 weeks of wound healing. Collagen here becomes mature and cross-linking occurs. There is maturation of collagen by cross-linking, which is responsible for tensile strength of the scar. In the normal skin, which is not injured skin, contains 80% type 1 collagen and 20% collagen type 3. In the granulation tissue, collagen 3 constitute more than 80%, while collagen 1 constitutes less than 20%. In scar after wound healing, scar formation after wound healing contains both collagen 1 and collagen 3 in equal percentage, 50% collagen 1 and 50% collagen 3. ده معناه ان normal skin is more powerful لان الكولاجين 1 هو اللي بيدي integrity of the tissue and strength, tensile strength. عشان كده في النورمال سكين الكولاجين 1 80%، انما الكولاجين 3 20%. في السكار افتر ووند هيلينج مهما يكون حتى لو انسايزد سكار هيكون الكولاجين 1 الى نسبة الكولاجين 1 الى الكولاجين 3 50 to 50. This stage needs vitamin C, iron, alpha ketogluteric acid. Collagen deposition in the wound is assisted by quantity of hydroxyproline excreted in urine. There is a balanced activity of collagen production and degradation of collagen, or what's called collagenolisis. Collagen is broken down by collagenase. There is collagen deposition and collagenolisis in a balanced manner until the scar is well formed. After 1 week, the scar strength is 30%. After 3 weeks, scar strength is 20%. After 12 weeks, the scar strength about 80%. There is some factors affecting wound healing. Here we are discussing or mentioning the factors which delay wound healing or impair wound healing. There are local factors and general factors. Local factors like infection, presence of necrotic tissue and foreign body within the wound, poor blood supply, venous or lymph stasis, tissue tension like sutures, taking sutures under tension, hematoma formation in the subcutaneous tissue, large defect or poor apposition of wound like lacerated wounds or devitalized or crushed wounds, recurrent trauma because this is healed by fibrosis which has less vascularity, X-ray irradiated area also because of thrombosis of the local vessels with poor blood supply in the local area, site of wound like wounds over joints and back because has poor poor healing because also poor blood supply because these wounds are over bones directly without muscle bulk beneath the wound, which muscle gives more blood supply for the overlying skin. Underlying diseases like osteomyelitis and malignancy also impair wound healing. Mechanism and type of wound. Incised wounds is better healing than lacerated wounds, better healed than crush wounds or avulsion wounds because there is tissue devitalization and poor blood supply. Tissue hypoxia locally reduces macrophage and fibroblast activity. There are also general factors impair wound healing, like age. Old age has impaired healing than adolescents or children. Obesity also impairs wound healing. Smoking because it causes hypoxia. Malnutrition احنا قلنا ان في فيسز فيتامين سي والايرون والبروتينز important for wound healing. Zinc or copper or magnesium deficiency also cause delayed wound healing. Vitamin C deficiency, vitamin A deficiency, anemia because the hemoglobin is low and this causes some sort of hypoxia. Malignancy, uremia and jaundice. These diseases decrease the immunity, make immunocompromised and delayed wound healing. Diabetes and metabolic diseases, as we mentioned before, and diabetes impairs chemotaxis and migration of leukocytes or neutrophils to the site of injury. HIV and immunosuppressive diseases, steroids and cytotoxic drugs also impair wound healing. Management of wounds. Management of wounds. Firstly, we must inspect and classify as per the type of wound. We must see this هل ده incised wound، هل دي lacerated wound، هل يعني complex wound ولا simple wound، closed wound or open wound. We must know the type of wound first. If the wound is in a vital area, then advanced trauma life support or ATLAS protocol of management is adopted, hand by hand with resuscitation of the patient by intravenous fluids and oxygen supply, and careful looking for any deeper communicating injuries or fractures or etc. If the wound is an incised wound, then primary suturing is done after thorough cleaning. لازم نعمل كليننج أول الوند خلاص. لو هو كان في الشارع أو في مكان not suitable، ما هواش في على يعني table of surgery or in a clean site، لازم نعمل thorough cleaning first, then primary suturing. If it is a lacerated wound, then the wound is excised and primary suturing is done. If it is a crushed or devitalized wound, there will be edema and tension in the wound. So, after wound debridement or wound excision, by excising all devitalized tissue, the edema is allowed to subside for 2 to 6 days. Then delayed primary suturing is done. If it is a deep devitalized wound, after wound debridement, it is allowed to granulate completely. Later, if the wound is small, secondary suturing is done. If the wound is large, split skin graft or terch graft is used to cover the defect, or flap, any plastic rehabilitation or plastic coverage. In a wound with tension، لو wound وتحتيه subcutaneous edema أو في devitalized muscles زي مثلا الليج، وفي severe tension يعني في severe muscle swelling، ممكن تعمل compartment syndrome. So fasciotomy is done to prevent the development of compartment syndrome. لو wound معاه vascular or nerve injuries, we must deal with accordingly. Vessels are sutured with 6-0 polypropylene non-absorbable suture material. If the nerves are having clean-cut wounds, it can be sutured primarily with polypropylene 6-0 or 7-0 suture material. If there is difficulty in identifying the nerve ends, or if there are crushing in cut ends of nerves, then we make marker stitches placed using silk as a site, and later secondary repair of the nerve is done. In case of trauma, either penetrating trauma or blunt trauma to hollow organ like the skull or chest or abdomen, may need craniotomy for subdural hematoma or extradural hematoma. If there is intrathoracic pleural effusion, blood collection, may need intercostal tube drainage. If associated with intra-abdominal injuries like organ perforation or laceration of the spleen, liver, etc., may need laparotomy. Has to be dealt with accordingly. Also, in compound wounds or closed wounds with fractured bone, also must be identified and properly dealt with. Don't forget to start your treatment, as we mentioned, with resuscitation of the patient with intravenous fluids, oxygen, antibiotics, fluid and electrolyte balance, blood transfusion if needed, tetanus toxoid or antitetanic serum globulin injection. In case of wounds with devitalized tissues like lacerated wounds or crushed wounds, wound debridement with wound towelette or wound excision, liberal excision of all devitalized tissues at regular interval until the wound becomes clean to make secondary suturing or grafting. ده في حالات الوونز اللي معاها devitalized tissues. ما ننساش طول فترة تريتمنت او المانجمنت اوف سيس وونز ان احنا نعمل على طول تولد ونعمل ووند اكسجن اول باول لاي ديد تيشوز تظهر جديد، ونخلي دايما there is healthy granulation tissue in the wound floor. يعني ايه primary suturing؟ يعني ايه delayed primary suturing؟ يعني ايه secondary suturing؟ primary suturing يعني suturing the wound immediately within 6 hours. It's done in clean incised wounds في خلال أول 6 ساعات. قلنا لأن الفترة دي اللي ما بيكونش فيها bacterial colonization، بعد 6 ساعات يبتدي يحصل bacterial colonization في الwound ويبقى ايه contaminated، يعني مش contaminated يعني colonized. في delayed primary suturing means suturing the wound in 48 hours up to 10 days. It's done in lacerated wounds or severely lacerated wounds which cannot be excised properly or closed primarily. ليه؟ لأن احنا عدت هنا 48 ساعة أو عدت أكتر من 6 ساعات، فهنا هيبقى colonized wound بالبكتيريا، فإتس بيتر إن احنا نعمل primary delayed primary suturing. تمام؟ يبقى دوت لو عدى على الوند من 48 ل 10 أيام. This time is allowed for the edema to subside. يعني هنا يبتدي يحصل edema في الوند، ولو أنا عملت stitching وفي edema ده هيعرضه للإنفكشن وهيعرضه إن يبقى السوتشرنج هيبقى under tension فيعمل local ischemia، فده برضه هيعمل ايه delayed healing or non-healing of the wound، ممكن يعمل dehiscence of the wound. Secondary suturing means suturing the wound من 10 ل 14 days or later. ده بيتعمل في infected wounds after control of infection. Once healthy granulation tissue appears, secondary suturing is done. عندنا complications of wound healing. ممكن يحصل من wound healing، ممكن يحصل infection، ممكن يحصل dehiscence ان الwound يفتح، يعني لو في factors من الفاكتورز اللي بتعمل delayed wound healing ويمكن يحصل wound dehiscence. وفي الثلاثة complications اللي قدامنا دول يعني common وبيحصل زي الهايبرتروفيك سكار والكيلويد والكونتراكتشر اوف سكار. الهايبرتروفيك سكار والكيلويد شبه بعضهم ان هو بيبقى في السكار تيشو بيبقى raised over the surface of skin. scar tissue raised over the surface of skin. فاهمين؟ يعني الهيلينج بيبقى باي فايبروزس بيكون raised above the surface of normal skin، ما هواش linear وسموث. ايه الفرق بين الهايبرتروفيك سكار وما بين الكيلويد؟ السكس انسيدنس الهايبرتروفيك سكار بيبقى equal in both sexes، انما في الكيلويد بيبقى more common in females. الريز في الهايبرتروفيك سكار no raise more than other، يعني ما فيش racial relation. انما في الكيلويد بيحصل more in blacks، اكتر في البلاكس، black races. الايج الهايبرتروفيك سكار more in children، انما الكيلويد more in adolescents والميدل ايج. more in adolescents and middle age. الهايبرتروفيك سكار has no genetic predisposition، انما الكيلويد بيبقى فيه genetic predisposition. طيب السايت فين؟ السايت في الهايبرتروفيك سكار في اي حته في البطن، anywhere in the body، بس اكتر في الفليكسور structures، يعني في surfaces، في الفليكسور surfaces. تمام، يعني لو في قصاد الجوينتس اكتر. انما السايت اوف اوكرانس اوف كيلويد بيحصل دايما في الشيست وول، الابر ارم، لور نيك، في الاير. الهايبرتروفيك سكار يحصل جروس للفايبروزيس دوت او فايبروس تيشو اوفر ذا سيرفيس او الجرانيشن تيشو مع فايبروس تيشو up to 6 months، يعني بعد 6 شهور خلاص stopped growth. اما الجروس في حالات الكلويد continues to grow without time limit and extends to normal skin. يعني ايه؟ يعني الجروس بتاع الهايبرتروفيك سكار بيبقى فيه raised scar over the skin surface ولكنه limited to scar tissue only، يعني اللي بيليميتد الحته اللي هي raised over the skin surface بتبقى over the scar بس. انما في الكيلويد extends to normal skin، يعني ايه؟ نلاقيها كده ايه؟ فرشه فوق النورمال سكين. تمام، extends over the limit of scar tissue. انما في الهايبرتروفيك سكار limited to scar tissue only. الهايبرتروفيك سكار ليه good response، تدي good response للسترويدز، انما في الكيلويد poor response. الريكارنس uncommon في حالات الهايبرتروفيك سكار، انما very high في حالات الكيلويد. very high في حالات الكيلويد. لو شفناها باثولوجيكالي هنلاقي ان في حالة الهايبرتروفيك سكار بيبقى الكولاجين سينثيسيس. احنا قلنا ان في كولاجين سينثيسيس في السكار، وان بيبقى التايب 1 تو تايب 3 50 to 50%. في الهايبرتروفيك سكار الكولاجين سينثيسيس ده بيكون 6 times more than normal skin، more than النورمال. في حالات النورمال اللي هو الريمودنج وان يحصل كولاجين سينثيسيس او البروليفراتيف فيز، ده بيبقى 6 times more than the normal. ويبقى تايب 3 فاين كولاجين هو الاكتر في الكولاجين سينثيسيس. اما الكولاجين سينثيسيس في حالات الكولويد بيكون 20 times 20 مرة more than normal. برضو هنا بيبقى التايب 3 كولاجين هو الغالب، بس الفرق هنا ان في الهايبرتروفيك سكار بيكون تايب 3 فاين كولاجين، انما في الكيلويد بيبقى تايب 3 سيك كولاجين. طيب الكلينيكالي قلنا ان هو الكيلويد ده بيبقى فارش فوق السكين، يعني more than the limit of scar، وبيبقى tender، وبيبقى vascular، وبيبقى itching. ده في حالة الكيلويد بيبقى tender وبيبقى فيه itching وبيبقى vascular. اما في الهايبرتروفيك سكار ما بيبقاش فيه tenderness no vascular and no itching. الهايبرتروفيك سكار عادة ما بيحصل له ريجريشن مع الوقت، اما الكيلويد بروجريسيف. اما في حالة الكلويد فبيبقى بروجريسيف. الكلويد بنعمل له بريشر جارمنتس او revision excision of scar and closure with skin graft، لكن زي ما قلنا ريكارنس عالي. contraction of scar هنا لو حصل يعني deep lacerated wound او devitalized crush wound over joint surfaces، يعني على حته فيها فلاكشر سايت، يعني حته كده في الارم opposite مثلا زي elbow joint او في الاكزيلا او في الفينجرز، وكان في lacerated wound وديفيتلايزد وعملنا اكسجن. عادة ما بيحصل السكن زي ما قلنا كده بالبلدي الجلد يقصر، ليه؟ هنا بيحصل contraction of fibrous tissue او contraction of the scar contraction، فبيبقى السكار ما بيديش نفس اللينس اللي كان في النورمال سكين في الاول. فهنا بيحصل كونتراكشن، فتلاقي يحصل ايه، ان الجوينت تلاقيه ايه فليكسد يحتاج ريهابيليتيشن او يحتاج بلاستيك سيرجري زي مثلا زد بلاستي او في واي بلاستي او ايفن سكين جرافتنج عشان تفرد تاني الجوينت، تعمل اكسجن للفايبرس تيشو ده وتعمل تفرد الجوينت وتعوض الحته اللي هي defect by grafting او by flap. ده بالنسبه لموضوع الwound healing والwounds عموما. Thank you.